So with, all right, there we go. So with no further ado, since we have quite a few people already signed on, I will let Itay go ahead and get started. Thank you
All
very
right.
much.
So thank you. Thank you, May, for the invitation and for everything that you guys have done to help me out during the year. So thank you. And I'm not going to be talking about my research. I actually am coming for hopefully for a discussion. And the question that I ask myself as a geriatric anesthesiologist is, where do we draw the line? Is there ever too old for surgery? And I'm going to start with my disclosures, obviously. You're not going to get an answer to the question. I will tell you some personal stories, some stories that I've been involved with in one capacity or another, and then some other things that I thought are worthwhile for you to hear. And at the same time, I'm going to I do have to disclose that um, I am the chair of the ASA's geriatric committee, and we did get some money from the Council of Medical Specialty Societies to improve diagnostic excellence. And some of the things that I will refer to come from this, I would say, initiative. So I'd like to start with my first personal story. I'd like to tell you about a 40-year-old female who comes in for elective cholecystectomy. So as my wife and I are going to have her cholecystectomy, we have one worry. It is that time when they close the I-90 bridge. We live on Mercer Island, and she's going to have her elective cholecystectomy in the morning. And what we're worried about, because we're Jewish parents, is that our kids will not have enough to eat, because we're pretty sure that around midday, when the Blue Angels start flying over Mercer Island, our kids will wake up, and what will happen? Who will feed the kids? There are no heartfelt goodbyes. There's no, we're not worried that something horrible is going to happen. This is the only thing that we are concerned with. And as you can see in the bottom picture, the same month, within those 30 days, we're out in the Cascades hiking with our dog and our kids, and all is well. And we've learned to accept that as really the only outcome, as only the reasonable outcome for something like that. But this is not true for non-Hungarians. When we look at the data for over 1,000 cholecystectomies, about one of them emergent and 80% of them elective from the NSQIP database, we see a completely different picture. When we look at their 30-day mortality, even in the elective population, we're talking about almost a 5% mortality. This is a lot. 1 in 20 and almost 1 in 10 in emergent cases. Does that mean that we need to admit anybody who's over 90 years old? I think most of us would suggest that that is the case. We're not going to have somebody who's 95 undergo a cholecystectomy and then send them home the same day. But is this really reasonable? I mean, what would be better when they stay in the hospital? What does it mean to stay in the hospital? And we have very different views of what is home and what is hospital and what does sleep deprivation and what is the environment. And I think we take all these things into account. So age alone cannot be a good enough indicator uh, for how we do stuff. And I think the general population is well aware of that. And this is from the New York Times. The elderly are getting complex surgery. Often it doesn't end well. And in fact, when we look at the data, it is kind of striking to me which percentage of the population, the older adults, get surgery in their last year of life. And you can see that the numbers in the sub 80 range are huge, but even in the above 90 range, still a significant proportion of older adults get surgery and therefore have to see somebody like me in their last year of life. And about 8% of them underwent that surgical procedure in their last week of life. So I'm sure that you want to do when you're an older adult to spend the last week of life with your loved ones, not with me. So can we identify those at risk? Um, my interest in frailty was really raised by that because we know that age is not a good cutoff. Somebody at 80 can be these all of these people pictured here are about the same age. They're in the same decade of life. And some of them are running marathons or climbing the Everest, and some of them are very debilitated, including one of my, I realized that I'm I'm showing myself as a geek and a nerd, but um, uh, you can see that in the bottom left, this is Leonard Nimoy, who, as a kid, I really admired Mrs. Spock, all reason and thoughtfulness, as he's being wheeled with oxygen across LAX. This is public pictures. So the American Society of Anesthesiologists has tried from the beginning to look and identify risk. First, almost 100 years ago, they created obviously what has to fail, which is a committee and to identify risks. And the committee published its work in anesthesiology in 1941 and dismissed the task as being impossible to devise. Later on in the 1960s, there was another trial, and this is still the standard that we all use today. And we call it the ASA score. It is supposedly a subjective assessment of a patient's overall health, and again, health. And look at the definition. ASA 1 is patient is completely healthy, fit. And then look at the definition. We talk about mild systemic disease. Patient has severe systemic disease, etc., onto patient 5, which is a moribund patient who is not expected to live 24 hours with and without surgery. During time, we've added the E for emergency surgery, and now we even talk about ASA 6, which are organ donors. But from 1963 till now, not only do we still use this classification, but we have to use this classification. Otherwise, we can't even bill for our medical bill. But this is what I would say most of us, most of the time, use as classification. We just talk about comorbidities. Now, there are better risk calculator. I think the one that everybody mostly knows is the surgical risk calculator, the NSQIP one. It was created with over 1 million cases, and it provides a lot of information, not just about expected postoperative mortality, but also about complication. I want to show you that in the new version of this score, the age as you can see in a red square, we put in age between 18 and 112. I've actually asked my colleagues in the geriatric committee how many of them have any experience giving anesthesia to anybody who's over 110, and amongst anesthesiologists who are interested in geriatric anesthesia, none of them had a single case, but still the risk calculator, and I don't know how they can do that, it's probably some linear regression, takes into account not just comorbidities, but also age and functional status, as you can see. And basically it spits out the risk of death, but also the risk of major complications. And I think, again, I really like this graph because it means absolutely nothing and it means everything. It is not based on anything, but what we have is on the x-axis, increasing age, and on the y-axis, we have the physiological reserve. And a blue line denotes the physiological limit that increases when early in life and then decreases until it basically falls off a cliff at one point. And we don't know. We can just say that it is increasing age. And if you're below the line, recovery is very likely. If you're above the line, recovery is unlikely. And then you could stratify it by high risk, medium risk, and low risk surgery. So young, healthy people can probably deal with most high risk surgery. And the older we get, the more difficult it is to deal with high risk and then medium risk surgery. So again, I want to tell you about a case that I was involved in her anesthetic. and you guys were involved in taking care of her as well. So 102-year female, this is 6 years ago. She had a ground level fall. She has a history of breast cancer, and she underwent a mastectomy in the 1980s. Again, this story is from 6 years ago. She may or may not, it's not clear from her chart whether she has bladder cancer. She was actually last seen by a physician over a year ago, although she lives in an assisted living facility. In the last 6 months, they do note that she's weaker and probably lost some weight. The only medication she takes is some furosemide and potassium cinnamon multivitamin. And again, she lives in an assisted living facility. She ambulates with a walker, and she gets some help with ADLs. When I talked to her, she told me that she enjoys good food, she likes to read The New Yorker, and she likes to talk politics. Well, the story begins in February 28th, 2018. She has a ground level fall in her assisted living facility from the walker. She has no loss of conscience, no pre-syncope. EMS is called to the assisted living facility. They look at her, they don't find anything, and then her back pain improves, except when she's ambulating. So they prescribe some NSAIDs and some bed rest, and all is well. Although it doesn't go well, on March 2nd, she has persistent abdominal pain, and she's taken to Swedish just across the hill, where they get a CT and find an unstable hyperflexion fracture of T12 with dish, large left pleural effusion, and a small chronic PE. They do what they do best, and they ship her to us. This is the actual picture of the CT showing. You can see it's obvious. You can see the fracture in the T12. If you can't even see the fracture, you can see how tilted her spine is. It's a very unstable spine. And you can see that she's got a very large left pleural effusion that, this is what we get. The surgeons see her in the ED and say, well, she needs an emergent T9 to L3 PSIF. So a 6-level PSIF. This is a large operation. They get Geri console, which the geriatric assessment shows that her echo shows diastolic dysfunction, which is completely not surprising at age 102. We all know that the heart becomes very stiff, so it doesn't relax, and diastolic dysfunction is, I would say, almost a rule at 102. Her RCRI, her cardiac risk, is actually minimal. She doesn't have coronary artery disease. She doesn't have any signs of congestive heart failure, maybe the pulmonary effusion, but nothing before that. She didn't have a CVA. Her creatinine is normal. She's not diabetic. And you could argue that it's not an emergent case. It is really an urgent case from the surgical perspective. Her functional status is reduced. She can, we like talking about metabolic equivalents. She's got less than 4 of them. And clinical frailty scale is 6 out of 9. But really, how many patients that you see who are 102 have more than 4 METs and are completely unfrail? Does she have a risk for delirium, which is addressed in the geriatric assessment? Well, does she have dementia? Yes, no, it's unclear. She is frail, and she is very, very hard of hearing, so definitely sensory impairment. The recommendations are no anticholinergics, no sedative, no uncontrolled pain. Well, make sure she doesn't have uncontrolled pain, which she doesn't at this point. And I see first the case. They talk to me about a 102-year-old who's coming in for a 6-level PSIF. And these are the things that are running through my mind. Roughly for every level of spine, you can expect, of a posterior spine, you can expect about 200 to 250 mLs of blood loss. So for her, this would be massive blood loss. I need appropriate lines. I need fluids. I need products, blood products. It's almost uncertain that she will have hemodynamic instability. So I need to prepare pressors and inotrops and potentially, some more ways to monitor her. She's going into prone position. And we know that in spine, when somebody goes into prone position, And the older they are, the higher the risk that they will develop blindness, intraoperative blindness. They do want to monitor unstable spines, so we are going to do neuromonitoring, somatosensory evoked potentials, and motor evoked potentials, which basically means for us that I need to change the way that I provide the anesthetic. I need to make sure that it is in line with that, and I need to prescribe a specific kind of anesthetic. How much analgesia do I give her? Maybe opioid-induced hyperalgesia if I give her too much remifentanil. She is very likely to develop hypothermia. Older adults develop hypothermia much more quickly. They don't show any clinical sign, and it is much, much harder to warm them. You all know that. She's not a diabetic, but probably glucose management is something. Will she have a cardiac event? It's all important. But in addition to, I would say, the things, I'm also concerned about the fact that she's got a very large pleural effusion. Could this be just cancer? And does she have a metastatic disease in her spine, and we're just prolonging this woman's suffering? And really, can somebody who's 102 years old undergo a 6 level PSIF? So again, I want to remind you, this is the Linda Fried classical thing that you guys have taught me. Frailty, comorbidity, and disability are different things. The Venn diagrams overlap, but you can look at each one of them. And in a survey that we did, greater than 80% of anesthesiologists who have answered our survey have never or rarely assessed frailty. So the only thing that I think we need to consider really in this lady is frailty. Well, because she is so hard of hearing, we get together, the geriatricians, surgeon, and myself, and a family member. And because she's so hard of hearing, we're having a discussion with this lady. And I picked up, again, because it's so hard to explain to her, we write down, she can read, she can understand, and you can see this is everything. And this is not everything, but you can see some of the discussion. Obviously, you can't see her responses. But basically, we ask her, do you prefer to have surgery on your spine, or do you prefer to skip surgery, knowing, et cetera, et cetera, et cetera? By the way, at that time, the surgeons are looking at us, at the geriatrician and myself. We're talking to the lady and the family in complete disbelief because it's obvious that she needs surgery and she needs it now. We decide to go for surgery. Nobody's willing to do her thoracocentesis. So I do it, I put her to sleep, do it in the OR. Actually, you can see below the chest x-ray that was taken in the OR with the endotracheal tube, showing that we removed most of the pleural effusion. We sent it for a quick lab. It didn't show anything that was concerning, and fluid was completely clear. So we go ahead with surgery. I insist that the attending surgeon, who's a friend, he's the first one who took me to see a hockey game in my life, come in, and he is there from the beginning. And I'm there the entire time saying, guys, no talking. We need to finish this quickly. You need to make sure you don't bleed her. And they do a wonderful job. They really do a wonderful job. 6 level PSIF, under 3 hours, estimated blood loss of just 200 ml. This is as good as we could possibly wish for. During the anesthesia, I give her propofol. The usual dose that I would give a person would start at 100 microgram per kilogram per minute. It's not uncommon for me to run it at 120 or 150 microgram per kilogram per minute. At 35 microgram per kilogram per minute, she's just at the level where she's burst suppressed, which means that we monitor her EEG activity, and at 35 microgram per kilogram, if I go a little higher than that, I create a state of no electrical activity in the brain, which is not something that I want because it's associated with increased postoperative delirium. Remi, again, low dose, not as low as propofol, but some low dose. I do run some pressors, And at the end of surgery, I give her just zero point 0.2 milligrams of hydromorphone. That's really all she needs. And she seems fine. You can see the x-rays, the intraoperative x-rays, and you can see the 6th level and the screws inside the vertebrae, and you can see the rods holding everything together. I go to see her the day after. I know that this sounds like a setup, but this is what she's reading. This is the Time magazine that she's reading as I go to see her in the ICU, How to Live Longer Better. I mean, you can't make stuff like that up. And she's sitting in a chair on the first day. I go to see her on the second day as well. She's having lunch. She did not recognize me, but she is reading a newspaper. I tried to talk a little politics to her, but I thought that all me trying to shout at her about politics, everybody looked at me like I was insane, and I was happy, and everything is fine. Well, this is Harborview. I go to see her on the 3rd day post-op, and I go to see her after I get a little break, and I'm there at 2 p.m. And I'm not happy. I'm not happy because she's lying in bed. She did not eat or drink. She had no reorientation. She was not by a window, and she was in clear hypoactive delirium if I ever saw one. And I'm unhappy with that. I talked to the nurses. I call the medicine attending, who's not a geriatrician. This is Harborview, so you know the drill. The medicine attending is actually from IM, and I am probably very, very unpleasant because in the chart, the medicine attending writes, and because I suggest that she needs all these things and she needs geriatric counseling, and she tells me that medicine knows how to treat older adults just as well as geriatrician, and I'm unpleasant. So she writes in her chart, I was paged by the surgery attending. So if somebody thinks that I'm a surgeon, I know that I was unpleasant. And this is so trivial. And I know that you know that the way to prevent delirium is really through little things. And I don't need to tell you that. You've taught me that, so thank you for that. I'm just trying to make sure that it gets implemented. Well, what happens to this lady? She gets discharged home to a SNF, not to her ALF, to a SNF in good condition on a little over a week after her surgery. And on post-operative day 23, she's admitted to Harborview in terminal condition, dies in the ED. There is no discussion about her situation. The only thing that people can talk about is the fact that she probably died from old age. And the first question, and the most important question that I asked myself, is should we have offered her surgery at all? I want to continue to another story. And again, I'd love to hear your thoughts on this, but I want to continue to another story. And this is not a patient that I took care of. In fact, it was almost impossible to get the information about this patient. But the story is so compelling to me about the decisions we have to make as people who treat older adults and the very old adults. I think it's so Lawrence Altman actually trained at UW. And this is from a piece at the New York Times. I actually reached out to the Methodist in Houston to get some more information, but they told me that they never had a patient like that. He's never written, you'll see. Anyway, so the story begins on December 31st, 2005. Dr. Michael DeBakey, then 97, so you know he's a doctor, was alone at home in Houston in his study preparing a lecture when a sharp pain, and I'm quoting, ripped through his upper chest and between his shoulder blades. It then moved to his back. And Dr. DeBakey, who underwent a full physical before that, knew his heart was fine. But as foolish as it may appear, you are, in a sense, a prisoner of the pain, which was intolerable. You're thinking, what could I do to relieve myself of it? If it became intense enough, you're perfectly willing to accept cardiac arrest as a possible way of getting rid of the pain. So Dr. Michael DeBakey thinks, my heart is fine. I probably have a dissecting aortic aneurysm. And I want to tell you a little bit about Dr. Michael DeBakey before we talk about dissecting aortic aneurysm. He is as close to Dr. James Bond as ever was one. His patients include King Edward VIII. These are all people he operated on. The Shah of Iran, Boris Yeltsin. He was actually flown in the middle of the Cold War to Russia to take care of Boris Yeltsin. Just some of the honors, just showing you the kind of recognition this guy has. Is the U.S. Army Legion of Merit, the American Heart Association Gold Heart Award. He received even a NASA Invention of the Year award, as well as at that point, the USSR provides two Lomonosov large gold medals from the Russian Academy of Science. He's the recipient of one of those two in 2003. So very well recognized, very well respected surgeon. He also is the one who's probably most likely to identify a dissection of an aortic aneurysm, thoracic aortic aneurysm, because the classification is named the DeBakey classification. So he's got a DeBakey 2 or a Stanford A, dissecting aortic aneurysm. And the reason we know that is that after his friends, his colleagues, the ones he taught how to do the operation that is named after him as well, come over, they have a discussion, they all agree that he probably, according to the symptomology, has a dissecting aortic aneurysm, but he's not really rushing to the hospital. He doesn't get a lot of treatment. It takes about 3 or 4 days for them to, remember, we're starting on December 31st. He's writing his lecture. On January 3rd, he's willing to go to have a CT that shows a 5.2 centimeters type 2 or Stanford A dissecting aortic thoracic aneurysm. He says that he doesn't want to be admitted to the hospital. He doesn't want to be operated on. He feared that the operation he had developed to treat this condition might, at his age, again, I'm reminding you, 97, leave him mentally or physically crippled. I'd rather die, he said. On January 6th, he actually gives the lecture that he was preparing on December 31st. He talks to the Academy of Medicine in Texas. There are in the audience, there is a Nobel Prize winners, there is a senator. He attends the luncheon. I'm not sure how you eat within dissecting aortic aneurysm, but then he goes home. Well, at home, he gets treatment for blood pressure at home. His second wife, German film actress, actually is there to take care of him. And they treat his blood pressure conservatively. His nutrition is, as expected, poor. He's short of breath. His kidneys are starting to fail. Fluid is collected in the pericardial sac. On January 23rd, he feels so bad that he goes to the hospital. On January 28th, they convince him to have another CT, and the diameter now from 5.2 increases to 6.6 centimeters. And Dr. DeBakey says he will reevaluate the situation in a few days and then decide. On February 9th, he is unresponsive. They get another CT. The aneurysm is now 7.5 centimeters. Mrs. DeBakey, his wife, says she prayed a lot. She also talks to a healer in Germany, and the healer says that it will be fine, and therefore she asks the team to operate on him. Again, her decision. The surgeons and the family decide to operate. They bring him down to the operating room emergently, where the Methodist hospital anesthesiologists say they are refusing to operate on him. They say that he has cited, they cite a standard form that he signed directing that he should not be resuscitated if his heart stopped. You all know that form. And a note in the chart saying he did not want surgery for the aortic dissection and aneurysm. Well, Mrs. DeBakey calls an anesthesiologist who used to work with Dr. DeBakey in the Methodist
and now works in another hospital in the DeBakey Heart Center. And the DeBakey Veterans Affairs Medical Center. And she comes over, and the anesthesiologist apparently physically stand in her way, saying that if that she brings Dr. DeBakey down to the operating room, they will call the police and she will be charged with assault if she ever touched Dr. DeBakey. Isn't this a great story? Well, the Methodist Hospital Ethics Committee meets on the top floor of the Methodist hospital. That's the only information that I was able to get, where the Hospital Ethics Committee meet. And they're trying to answer a crucial question that I'm asking you to consider as well. As his physician, what did they believe he could choose for himself in such a dire circumstance if he had the ability to make that decision? Dr. DeBakey, on one hand, said it was time for nature to take its course, but also that doctors had to do what they need to. Again, these are all quotes in bold. Some said that everything Dr. DeBakey did was for his family, and the family did want an operation. And after the committee members are meeting for an hour, this is a late, so you have to think about it. This is the morning they decide to operate. They try to bring him down. Anesthesiologists say no. They call another anesthesiologist. He comes over. Anesthesiologists are in her way. The meeting starts in the evening. And they're talking and they're discussing. And Mrs. DeBakey charges into the room and says, my husband is going to die before we even get a chance to do anything. Let's get to work. The discussion ends. The majority ruled in consensus without a formal vote, and no minutes were kept. Again, maybe there were minutes. The Methodist Hospital claims that they never had Dr. DeBakey as a patient. The start time for this operation is 11 p.m. Just the time we all love to start our complicated operation. And this is a picture of Dr. Michael DeBakey doing the DeBakey operation. And they say that he was a perfectionist, intolerant of incompetence, sloppy thinking, and laziness. Again, February 9th, 11 p.m., he gets operated on. Between February and March 2006, I think you know some of this course. He's in a windowless intensive care unit. He's delirious. He's unresponsive. He gets a tracheostomy. He gets PEG. He's put on renal replacement therapy and then dialysis. He gets mechanical ventilation for 6 weeks, numerous infections, nothing that surprising. However, he gets better. He gets discharged home on May 16th, 2006, and readmitted on June 2nd. On August 21st, when they round on him, he's not waking up, but then they talk about an older roller pump that he helped devise on the cardiac bypass machine. And he wakes up, he opens his eyes and gives the doctors a short lecture about how he had improved it over existing pumps. The care of it is incredibly expensive. But again, the Methodist Hospital declines to say whether they had a patient. He was there under hospitalized under a pseudonym. So the only thing they are willing to say is that they had no patient by that name. When he does wake up, he says that he does not remember signing an order saying do not resuscitate them. And he thinks that the doctors did the right things. Doctors, he said, should be able to make such decisions without committees. This is President George W. Bush, I know, with Nancy Pelosi and Harry Reid giving in April 2009 the Congressional Gold Medal. So he's got one from Russia and one from the US. And you can see it's a lovely picture. And on July 11, 2008, Dr. DeBakey died at age 99 of natural causes at the Methodist Hospital, et cetera, et cetera. So the question that I would love for you to help me answer, can we do better? Are we doing the right thing? almost 100 years ago, there's this beautiful painting of the Fountain of Youth, people coming in old and sick and coming outside healthy and young. And over the last 500 years, we were unable to identify that. But I wanted to make sure that I hear your stories. So I'm going to stop here. And I was told that you have a form that you have to fill. I've created, I'm not sure if it's effective or not, barcode so you can scan it. So I thank you for your time. And again, I thank you for everything that you guys have taught me. And I'm looking forward to learning some more.
Thanks for your talk. You teach us a lot all of the time, and not every geriatrics division has an anesthesiologist so enthusiastic about aging and geriatrics who comes to their meetings and collaborates on research. So we're really grateful for all that you do and all of your teaching. There are a few comments in the chat and we have time for questions, but it looks like if we want to start off with the top, Kay, I don't know if you are able to unmute, but she mentioned a risk calculator that's used at the VA and some potential obstacles to that being utilized.
Yeah, so the VA has VSQAP, which is so NSQIP, I think I understand, but maybe Itay, you know better than I do. I think was developed actually after VSQAP was developed. And my understanding, it might be a little bit, again, VA to VA, but I know at least in our local VA, that's done actually after a person is like already kind of, basically been seen by surgery, maybe even had their surgery, right, to help calculate the OE. And it's done on a variety of different cases. So it's not, at least in my understanding, it's not utilized by most surgeons, let alone anesthesiologists, as a way to do risk calculation. Instead, the risk analysis index, the clinical, that RAIC is what now is being more utilized as kind of like a point of care helpful decision tree. And that's what we've been starting to look at here at VA Puget Sound. To your point, though, about the kind of more subjective things, I think that's where I and others have some questions about how accurate and helpful that may or may not be related to functional status. Because I think one thing that I've wondered is how that's captured and how well it's documented, and then how accurate it is in any of these types of tools related to, again, risk calculation.
So first of all, I saw in the chat that Jenny was there. Yes, Jenny, I didn't want to out anybody, but Jenny was there in the room with me, with the family, and I'm sure that she still remembers. Now, about the risk calculator, I do want to say one thing, which I think is an opportunity. So if we're talking about the VA system, Jason Johanning from the Nebraska VA system, who has developed that RAI, has actually done an amazing job. He created a kind of a system in which they assess frailty at the preoperative level, and they have it's a multi-dimensional frailty assessment. It includes grip strength, it includes walking speed, it includes some other tests. And it maybe 7 years ago, they published in JAMA Surgery a very telling manuscript in which they did one intervention. When frailty was identified, the system stops. And when the system stops, there's a discussion. They didn't prescribe what would be the intervention. It could be that the surgery was changed. It could be that the surgery was canceled. It could be that the patient was prescribed nutrition or physical activity, or just but there had to be a discussion about the patient, at least between the surgeon and the anesthesiologist. And just by identifying frailty and making sure that everybody is aware of it, without even prescribing what is the intervention, they were able to reduce mortality. Again, this is a pre-post study. It's obviously very dirty, but I think it identifies something that is very important, and I think that communication is key. I think ultimately that's what we need to do. We need to sit with anesthesia and geriatricians and surgery and decide better.
Yeah, I agree. I was actually fortunate enough to present with Jason and Shipra like about a month ago. And they're fantastic. And I think one of the things that stuck out to me that I think you spoke to too today is that there is no high risk surgery, that there's like more high risk individuals. And I think your comments about cholecystectomies kind of hit that point, right? That we need to start rethinking about the surgery, not so much about how riskful or not riskful it is, or how much it intervenes or doesn't intervene, causes openness or whatever, but really thinking about the individual. So it was really exciting to hear them say something like that.
If there are any other questions, feel free to unmute.
Itay, what are your thoughts on the best way to assess frailty in a patient who is not able to do the classic frailty? I mean, we've talked about this a lot in research areas, but there's a lot of data we can get even in a patient who's unresponsive. And I'm just wondering where you think that field is headed. Is it going to be ultrasound? Is it going to be, where do you think? Opportunistic CT? I mean, there's just seems to be a wealth of information we can get on our trauma population that
I think we don't know. I think the first thing we need to do is make sure that we start at, and again, you can tell me at which age, whether it'll be 55, 65, or 75, but I think we need to start assessing frailty for every older adult. That has to be the start. The fact of the matter is we do not assess frailty. And I think that the same way that we identify fall risk in taking care of our patients, we need to start identifying frailty. Ideally, this would be an automatic thing, whether it would be radiological or, being something like we could extract from the Kenneth Rockwood method of just doing a frailty index that would come up for every patient that would automatically mind the chart and do that. It could be the clinical frailty score that we provide right now at Harborview, which is just a 9-point pictorial supported decision. But really yes, there are so many options that can be implemented, but I think people are unaware of it, and we need to find a way to assess it. It has to be in every patient chart, the same way that I need to write an ASA in every patient chart. And once for older adults, obviously, and once there is that, I think it can create the discussion that we wish to do. I think doing it is the discussion. Which tool? I don't have a very strong preference to one or another.
They just mentioned the VA RAIC as their tool, which is automatically done, which is great. Who does that, Kay? Is it the clinician or is it a nurse who does the intake? And if Itay wants to show that landmark study from the VA about frailty, situational awareness, and survival, I have that slide if anyone wants me to send it to them.
Yeah, it's kind of du jour, as most things are sometimes in VA, related to who does it. It can technically be done by patient and or a provider. We've looked at it in a couple of ways here locally, and we find that there is a little bit of discrepancy, even though hypothetically both ways are validated. So I would just say caution with related to, but you can actually print off an RAIC and hand it to a patient. And they can technically fill it out themselves and hand it, or a care partner, and hand it in, and then it can get automatically integrated. We did find that you need to kind of, irregardless, providers probably also do need to have a little bit of training related to it, but it doesn't take much. It's more like them actually doing it. That's where we found the poking needs to be done, is that people actually remember to do it. It doesn't take very long. And there's been a couple of studies, particularly out of UPMC/VA Pittsburgh, that have looked at that. The one thing I will just share too that we found personally, and I don't know if Amy's on this, she can jump in too, because she works with me very closely on this project with Marinee Kaligi at the VA. But we found that patients, so I'm certain it is the same for you all, right? Patients have access to their charts and can read their notes. And one of the things we did to help streamline the frailty screening process and to integrate that calculator and then put it easily available and identifiable within EHR is created a frailty screening note, literally called frailty screening note, in which RAIC automatically populates. And when you open up the template, you actively do the online calculator, and then it puts the results within the note, and then it gets signed and solidified within EHR, in our case, CPRS. Patients can read that. And we've had some negative patient feedback related to the name frailty, and not wanting that, A, to be in their chart, and B, maybe having some like mixed feelings about that term. Not surprising. And I think it was a really nice opportunity for us to kind of sit back and think about that, that term that clearly is loaded in an ageist society, and to really rethink, again, how we approach frailty screening, how we talk about it with patients. It made us actually sit back and rewrite so again, when we hand the sheet out to patients, rewrite the kind of like instructional bit at the top, and kind of explaining why we're doing this and how this will not necessarily prohibit them from getting things, right? But that this is an opportunity to think of how best to optimize and have important conversations about their goals and priorities prior to a major event. Anyway, so those are some of the lessons learned that I will share.
That's really important. It's kind of like BMI, back when, that was the big fear, was labeling patients' body mass index with some type of adjective. I just want to add one more thing. At Harborview, what happened was we had the Jury Council had a frailty initiative using the CSF9 in the trauma population and the burn population. And what happened was when they set up Epic, it automatically fires now for anyone 65 or older. So it was a great Epic error that results now in it automatically showing up as a nurse fill-in for anybody 65 and older. It still only gets done about 2/3 of the time, but it was one of those epic errors that actually we think was a good error. I'll stop there. I think Pam has a question.
Oh, I just want to thank you for this very interesting discussion, Dr. Benton, and also just this discussion. I was thinking, what would we say besides frailty? And somebody put in the chat functional status, so that might be, as I'm getting older, that may be more palatable. But I just, from a palliative care perspective, I was thinking of how we present things. That like in oncology, they'll talk about, instead of saying, you have a 90% chance of, succeeding, instead focusing on, you have a 10% chance that you could die from this. And I believe there's some literature that says that when you focus on the negative outcomes, there's a whatever chance, 40% chance you'll be bedbound after this surgery, that really changes people's perspective. I was just wondering if there were any comments about that. And also I think Kay put in the chat about we default to the highest level of care. We just do that in American society. And this is tough. These two cases just are giving me the heebie-jeebies.
So I actually wonder about that. I'm sure that some of you that there is the old railroad. The man stands and with a lever on a railroad crossing, and he needs to decide whether to activate the railroad crossing. And it doesn't matter. The point is, when I talked about the about the Bakey case to my anesthesia colleagues, they almost uniformly thought that it was crazy to go ahead with surgery. When I talked to my surgical colleagues, a very large portion of them thought, you see, this is so good. We should have, I mean, this shows the point, doesn't it? Look at the congressional medal with President Bush. I wonder what you guys are thinking.
And I wonder what Dr. DeBakey's quality of life was in those couple years he had.
Yeah, I thought about that too, Itay. I guess when I saw that he got the congressional medal a couple of years later, some people that's worth it, right? When we think of milestones, I mean, clearly he probably didn't know he was going to get that, I presume, right? But I think about people who choose to go through painful things in order to meet a certain type of milestone. And I think to Pam's comment is, I think hard to know, right? It's hard to predict what that pain will be for ourselves and how we may or may not like it. And how that reward, quote unquote, I guess you could call it, maybe that's not the best word to call it, but how that balances out the painful bits.
The question is also to me, as it's often happens with older adults who come into the hospital after trauma, they're very delirious, as for all the obvious reasons. In Dr. DeBakey's case, he did not make the decision to operate. How much do we allow the caregivers to decide? I mean, we don't have really the tools to make these decisions. Who should decide? Is it the caregivers, the patients? Is it just doctors? I don't know. What's your gut feeling? I don't have an answer to that. This is for me very difficult.
Marissa has a comment. Marissa, did you want to talk about that?
Sure. I mean, I just think back to the fact that we often spend so much money on these individuals at that. You mentioned it. So I thought I would just not ignore the fact that you did talk about his healthcare bills and the resource utilization. And, how much do we care about an individual or family's desire to prolong life? To what end and what use to society? And the privilege that this, phenomenal individual who contributed to many's lives had, but at the same time, it's not really just in a lot of ways. And so how do we make these decisions? And is it really up to us to make these decisions as providers? It's tricky. I'm curious. I just think we can't ignore that,
Yeah, I think from the ethical point of view, I agree with you, Marissa, that, when you look at healthcare costs in the last year of life, Medicare healthcare costs, it's like, really extreme. And, when you look from an ethical point of view of justice, we're so focused on the individual and we're not giving vaccines to kids, because of money, not necessarily philosophy. But there's so many healthcare dollars that could be spread across many different populations, even older population, but we're spending millions of dollars on one person. That I thought the story for Dr. DeBakey was going to be that he died, within days. So I'm surprised he lived that long. But the ethical point of view is very hard for me in this kind of situation.
I don't have an answer, but if anyone does, that would be great.
I mean, it gets a lot into American individualism. When we're in other, I don't have experience in other healthcare systems, in England or Canada or other countries where they would just say, we're not offering you thoracic surgery, in this case. But I think American individualism is just wins the day, unfortunately.
Definitely a lot came up as a result of your presentation today, Dr. Bentov, and I appreciate you helping us all think deeply and have this discussion. And thank you again for your teaching and for all you do for older adults and for all of us. I think this was, it brought up a lot of good questions that we can't answer in an hour, and that will be different with every patient that we approach, but good to keep thinking about it and working together across disciplines to do the best thing for patients and society. So thank you all for this great discussion. And again, thank you, Itay, for presenting this morning.
Thank you. Have a great weekend.
Great weekend, everyone.